Hello and welcome to another Intensive Care Hotline and Intensive Care at Home live stream. Thank you so much for joining today, and I also want to welcome you if you're watching this on replay. Today's presentation is about 10 proven strategies to wean a critically ill patient off the ventilator and tracheostomy. Now, I will go through that step by step, and if you have any questions, please, shout them out here. I can also bring you on live on the show here if you want to talk to me directly. If we have time, you can also ask me any other questions related to intensive care or intensive care at home. But we will go through that into much detail as we go along today. Now, what makes me qualified about talking 10 proven strategies to wean a critically ill patient off the ventilator and tracheostomy? Well, I have worked in intensive care / critical care for nearly 25 years in 3 different countries. I am a critical care nurse by background. I have also worked as a nurse unit manager in intensive care for over 5 years. I am the manager as well as founder of Intensive Care at Home, where we send intensive care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies. And we have been, in business with intensive care at home for the last 10 years. I've been consulting and advocating for families in intensive care all over the world since 2013. So for over 11 years, you can find all the information about that at intensivecarehotline.com. We have testimonials there, client interviews. We have saved many lives through our consulting and advocacy in intensive care. With intensive care at home, we've also been in business for over 10 years. We are currently operating all around Australia in all major capital cities, as well as regional and rural areas. And if you need intensive care at home and you are in the US or in the UK, I also encourage you to reach out. We can help you there privately. You can have all the information about intensive care at home at intensivecareathome.com. Now, as far as today's presentation is concerned, let's get right into it. So once again, we're talking about 10 proven strategies to wean a patient, adults and children, off the ventilator and tracheostomy. And like I said, I'm coming from a background of nearly 25 years of critical care nursing in intensive care, as well as with intensive care at home. And I believe I have a vast amount of experience in that area. that, you know, I want to share publicly here, because I don't believe that intensive care units are sharing enough about these issues, and I don't think they're making it transparent either. So without further ado, let's look at that. Now, before I go into the strategies, let me be very clear that I'm talking about patients in intensive care that don't have a high spinal injury like C1, C2, that do not have a neurodegenerative condition such as motor neuron disease, cerebral palsy. So I am talking about reversible conditions here, you know, such as lung failure. Lung failure is often a reversible condition, or, you know, patients in ICU that might have conditions such as they might have complications after cardiac surgery. They might have sustained a trauma like a motor vehicle accident. You know, they might have Guillain-Barré syndrome. Again, they might have been on ECMO. They might have had a heart transplant, a lung transplant. That's what I'm talking about. Those reversible conditions, how to wean someone off a ventilator like that. Like I said, I am not talking about spinal injuries, neurodegenerative conditions such as motor neuron disease, cerebral palsy, etc., etc. For example, people that live in the community on ventilators with tracheostomy, which is what we are obviously doing with intensive care at home. Those are the patients that cannot be weaned off the ventilator and the tracheostomy most of the time. Okay, so let's look at the 10 proven strategies in more detail. So the first strategy is to actually have a plan, right? So because we talk to families in intensive care all over the world every day, and we're, you know, dealing with situations like that every day, where family says, well, they're not weaning my loved one off the ventilator, you know, shouldn't they be doing this quicker and so forth? Well, my first question to that is, what is the actual plan? Do they have a plan? And then we often hear, well, they haven't mentioned anything about a plan. Okay, right, that's a big issue. What should a weaning plan look like? Well, let's break this down. A weaning plan should look like that, you know, patient in intensive care is often what's called in a controlled ventilation mode. That means the ventilator is doing most of the breathing for the patient. What does that look like? Well, it looks like they are in an SIMV ventilation mode or in an ACV ventilation mode, and they get delivered a set rate, a set breathing rate by the ventilator. So, you know, they're getting 12, maybe 15 breaths per minute delivered by the ventilator, right? At either a certain volume or at a certain pressure. Now, it doesn't matter which way, whether it's volume controlled or pressure controlled. I'm not going into that today. I just want to focus on the weaning aspect of things. So let's just say, you know, your loved one gets 12 breaths per minute delivered by the machine, and they're breathing on top of that. Okay, let's just say they're taking another 5 extra breaths, and those breaths are adequate in volume. You know, they're taking good breaths, they're not getting exhausted, right? Well, let's reduce the rate that they're being given by the ventilator. Let's just say the rate is 12. Let's just reduce it by 5 rates. Let's just put it down to 7 breaths per minute and see whether your loved one can breathe up on top of that, right? If your loved one can breathe up on top of that, well, then it's time to reduce the rate and gradually wean it. If that is achieved, let's change the ventilation mode to something called CPAP or pressure support, which is where the patient only gets a PEEP or 2 levels of PEEP if it's BiPAP, CPAP and pressure support. Again, I'm not going into too much detail what that exactly means. I'm just going on that now the next level is for a patient to breathe on CPAP or CPAP and pressure support. And once that can be achieved, it means that your loved one is breathing with minimal support from the ventilator, still with a little bit of PEEP, a little bit of pressure support. Again, if your loved one can tolerate that, is not getting exhausted, the breathing rate is within normal limits, sort of between 10 to 25 breaths per minute. The volumes that they're breathing in and out are adequate in volume, in size, you know, adequate according to your loved one's weight. You know, arterial blood gases are good, chest x-rays look good, your loved one is obeying commands, ideally. Then let's move on to a spontaneous breathing trial, i.e., let's take the ventilator off completely and let's put on a trach mask or a trach shield or a trach collar, right? And then once that's been achieved, there might be some trial and error. Maybe your loved one needs to go from ventilation with tracheostomy to a trach collar for a few hours a day, back on the ventilator, back on the trach collar. If that can be achieved, sort of you go back and forth and build up the strength from there, eventually your loved one hopefully is able to come off the ventilator. The same, going back one step to the beginning where I said your loved one is in a controlled ventilation mode, such as ACV or SIMV, once they can tolerate some CPAP or some pressure support, maybe they need to alternate to build up the strength, until they can be on CPAP or pressure support 24 hours a day. Once they can be on CPAP or pressure support 24 hours a day, that's when you can look once again at the next steps, which is doing a spontaneous breathing trial. So it's often not a smooth process. It's often a step-by-step process. You have to alternate between, SIMV, CPAP, until they can breathe CPAP continuously for more 24, 48 hours a day. Once that can be achieved, then you can move on to a spontaneous breathing trial with a T-piece or a trach mask or a trach collar, right? So I hope that makes sense. But there needs to be a weaning plan. And that leads me to the next point. Part of that weaning plan needs to be mobilization, i.e. your loved one needs to be able to have physical therapy or physiotherapy. They need to get out of bed every day. So imagine you're lying in bed for weeks on ends with a critical illness, and your muscles will decondition pretty quickly, including the breathing muscles, right? So how can you get off the ventilator if your breathing muscles are weak? It's not going to happen. So one way to strengthen breathing muscles is, like I said, physical therapy, physiotherapy, doing breathing exercises, doing coughing exercises, but also to mobilize. And mobilization means that your critically ill loved one has to get out of bed. Imagine they're sitting in a recliner chair, what that does to building up the breathing muscles, right? Well, it does a lot to build up your breathing muscles. If you're sitting upright in a chair, your breathing muscles automatically have to get strengthened. And in the beginning, your loved one may be slumped in a chair because they don't have the strength, but you have to start somewhere. I'm getting sick and tired of intensive care units telling families, well, we can't mobilize your loved one yet because they're too weak. Yeah, sure, I acknowledge that. But how do you get them stronger? Well, you only get them stronger by mobilizing them. That is the bottom line. How do you run a marathon? Well, you only run a marathon by training. If you're lying in bed all day, you won't run a marathon. You start with putting your first step in front of the next step and so forth. That's the only way you can get ready for something, right? It's common sense. It's common sense. So mobilization is critical, but it has to be every day. Ideally, it starts in the morning after, morning care has been given, maybe after a shower. Ideally your loved one has a shower, at least has a good bed bath, then get them out of bed for a couple of hours, rest over lunchtime, and then back out of bed in the afternoon, and then back to bed at night. And that will also help with a good day and night rhythm. It will also help with your loved one having a good day and night rhythm. And many patients in ICU, their day and night rhythm is all over the place. And that stops them from weaning off the ventilator. It's like if you work during the day, if you exercise during the day, you sleep well at night. It's the same in a situation like that. Don't move away from what is common sense. Don't let anyone convince you that moving away from common sense is a good idea, right? Follow your gut, follow your gut instinct here, So don't let anyone persuade you that mobilization is not a good idea. The only time mobilization is not a good idea in ICU is if someone, God forbid, has a fracture, is waiting for surgery. If they are hemodynamically unstable, if their vital signs are all over the place, if they are on multiple inotropes, vasopressors, vasodilators, if they have a traumatic brain injury, which is not resolved yet, then you can't mobilize. But for anyone that is stable and the only thing that's keeping them in ICU is the ventilator with the trach, right? Mobilization is absolute key. Absolute key. Next. When, a certain level of weaning off the ventilator can be achieved, if your loved one has passed some breathing trials, some spontaneous breathing trials, which include CPAP, pressure support, BiPAP, as well as trach collar or T-piece or a trach mask, then it might be time to downsize the tracheostomy, right? For simplicity, if your loved one has a size 8, maybe they can move towards a size 7, because then your loved one needs to do more breathing themselves. If they can tolerate that, they can knock it out of the park, then let's maybe reduce it to a size 6 and so forth, right? So once again, it is common sense to downsize a tracheostomy. That's assuming everything is moving in the right direction. Now, I also know that the question inevitably will come up, how long will this all take? And there's no hard and fast rules. I have seen it taking from a few days to a few weeks to a few months, right? It depends on a number of scenarios. It depends on age, or on condition, on, mindset as well. It depends on the ICU. Are they positive? Are they negative? Do they believe they can achieve that? So it depends on a number of things. There are certainly some variables around that. Okay. Next. Good nursing care is critically important with all of this. So what do I mean by that? Good nursing care means, like I said, having regular bed baths, having regular showers. And once again, don't tell me if the ICU is telling you they can't do showers, they are not being truthful. Every ICU has a bathroom, they have shower trolleys. There's no reason why your loved one can't have a shower. Absolutely no reason. Maybe not every day. ICUs are busy, I get that. But at least every couple of days, every few days, at least once a week. Imagine how much better it will make your loved one feel if they have a shower. How much better do you feel if you're healthy once you had a shower? Again, I always refer back to what is common sense. That also includes good mouth care, brushing teeth, making sure your loved one gets their back washed, gets their back rubs, gets maybe cream on their back, cream on their body after a wash, after a shower. It's all about feeling well, smelling nice. Again, that is common sense. But, in this day and age, it's also, we've got a new generation of nurses coming through. Do we call them laptop nurses? I don't know. I'm probably a little bit more old-fashioned. I did my training in the 1990s, but, washing a patient, giving good basic nursing care is so important, can't be overstated. Also, with the mobilization part, so moving on to the next point is, also the mobilization part also prevents pressure sores and it prevents contractions, right? One of the issues and challenges when someone is in intensive care long term is they are at high risk, super high risk of pressure sores. If they're staying in bed for too long, they might get pressure sores on their sacrum, on their elbows, on their hips, on the head, back of their head. The risk of getting pressure sores is huge. And that's why, again, mobilization, physiotherapy, good nursing care, turning patients from side to side, making sure the skin inspections are happening all the time, to see redness, to see skin tears, so they don't develop into pressure sores. To begin with, physical therapy, moving arms, moving joints, moving legs, again, preventing contractions as well. Very, very important. Once again, if the ICU is telling you they can't do that, they don't have the resources, I call nonsense, and you need to enforce what you need and what you want for your loved one, and we can help you with the advocacy around that here at intensivecarehotline.com. Next, whilst I have already mentioned it, it is a separate topic as part of the 10 proven strategies, is really to move towards spontaneous breathing trials as quickly as possible. Sometimes that can be done quickly, sometimes it takes longer. That's what I'm saying. I have seen patients being weaned off the ventilator and the tracheostomy from anything within a few days to a few weeks to a few months, right? There's no hard and fast rules. But one important aspect of the weaning of the ventilator and the trach is to do spontaneous breathing trials as quickly as possible. And like I said, there are two steps to spontaneous breathing trials. One is to go from a controlled ventilation mode to CPAP or pressure support, right? Which is the lowest setting on the ventilator. And once CPAP and pressure support have been weaned to a minimum, what do I mean by being weaned to a minimum? I mean by that to wean PEEP to about 5 and to wean pressure support to around 8 or 10, probably 8 rather. Volumes need to be good. That means the volumes that your loved one is breathing need to be between 10 to 10 mils per kilo, roughly. So for simplicity, if your loved one weighs 80 kilos and you take 7 to 10 mils per breath, that would mean your loved one needs to breathe between roughly 600 to 800 mils per breath. But more importantly, they can't be breathing too fast, they can't be breathing too shallow, they can't be breathing too slow. So the breathing rate needs to be, between 8 to 30 at the most, with good tidal volumes, good minute volumes. Arterial blood gases need to support that breathing can be sustained. Arterial blood gases, PO2 needs to be above 70 or 80 millimeter per mercury, and CO2 needs to be between 35 to 45 millimeter per mercury. So then once that can be achieved, then you can move on to a spontaneous breathing trial just with a T-piece or a trach collar, trach mask. Take the ventilator off completely. Now, all of that can happen in the following ways. Going from a controlled ventilation mode such as ACV or SIMV to CPAP or pressure support, you might go on CPAP and pressure support and it might only last for 5 minutes, might only last for half an hour. Okay, then you do that and you go back, but you keep trying and you keep building it up, right? Build up the time that your loved one can breathe on CPAP or pressure support. Build up that time, right? That's how you build strength. And also, again, it is so much easier to get someone off the ventilator if they can be mobilized to strengthen breathing muscles, to strengthen upper body muscles, right? But it might happen gradually. The same happens once your loved one can sustain CPAP and pressure support. When you then move on to the trach collar or the trach mask or the T-piece, right? Again, it might only be 5 minutes in the beginning, might be 10 minutes, it might be half an hour, it might be 2 hours, but you got to alternate between both to build up the strength and not get your loved one too exhausted, if that makes sense. Okay, so that's the spontaneous breathing trials. And then the ultimate goal is to have someone breathe spontaneously 24 hours a day so you can remove the ventilator completely. Next, once spontaneous breathing trials are in place, right, and are happening regularly, the next thing that can happen is using a speaking valve. So speaking valve is a valve that can pop on the trach to get someone with a trach to start talking again, right? That is really important. Communication is important. So if you take a speaking valve, you also need to let the cuff down of a tracheostomy. Otherwise, the vocal cords are paralyzed. So the cuff needs to come down, speaking valve needs to go on, and then, ideally, a speech therapist is in charge of that and will help this patient to learn to talk again. Okay, so really, really important, and that can also take time. I've seen that happening, over days. Many days, sometimes over many weeks. Unfortunately, patients are weak. And it often doesn't happen straight away, right? So let's move down this sort of cascade. Once your loved one is off the ventilator, can breathe spontaneously just on the T-piece or on the trach collar, on the trach mask, then it's time to not only use the speaking valve, but also to try and get the cuff down, Okay, so what do I mean by getting the cuff down? So letting the cuff down on a trach means that the airway is open, but there's also a risk for aspiration, right? So, but once cuff is down and breathing can be sustained and there's no aspiration, you know, that is the right next step, and that is a good situation for your loved one to be in, right? Once cuff can come down. Next is capping. Now you need to give me 1 second. I need to get a tracheostomy in the picture here so you can actually see what I'm talking about. Just give me 1 second, please. While I'm getting a tracheostomy, I should have prepared that a minute ago. I will show you in a second what that looks like. I'm back. So I've got a tracheostomy here. You can see that. And you can see that this is the cuff that I'm talking about. You can see it's up now. That prevents a patient from aspirating, but it also makes sure that as long as your loved one is ventilated, that the volumes are being given. Otherwise, there would be a leak. So once the cuff is coming down, as I'm deflating the cuff now, you can see that. Okay, cuff is down. That means there's a higher risk of aspiration because the trach is no longer blocked, and you know, sputum, secretions, gastric content can move down into the lungs, which puts your loved one at risk of aspiration pneumonia. Right, you don't want that. But then once that can be achieved, once the speaking valve can be used, once you know, there's no risk of aspiration, I tell you what should happen next. What can happen next then is to cap the trach. You can put a cap on, or you can put like this. Hang on, I'll show you. So you can put a cap on like this, and then the trach should be blocked, and then your loved one can breathe through the nose, right? That's the next step. If that all of that works, then your loved one hopefully is ready to have the cannula removed, right? So, and like I said, it also needs to be downsized along the way. And there's more steps, you know, that I haven't talked about yet. So we're not there yet. What you need to do in the meantime, though, is to lead up to all of this. You know, patients need humidified oxygen. Very, very important that you give humidified oxygen and humidified air. It's very important that you're not only reducing PEEP and pressure support, it's also important that you reduce the oxygen that's given. You know, before you take a patient off CPAP or pressure support and put them on a trach collar, ideally you would want to reduce oxygen. You know, room air, the air that you and I are breathing, is about 21% of oxygen. So when someone is on a ventilator, they often start off 50% of an oxygen, often going down to 40%. You know, once you take someone on the spontaneous breathing trial on humidified oxygen, hopefully you'd be less than 35%, just to illustrate some important numbers here. Also, your loved one will need to get regular nebulizers, right? And that can just be saline nebulizers. You know, sometimes patients need Ventolin or salbutamol, or they need Atrovent if they have other respiratory conditions such as COPD, asthma, or emphysema. But often just a saline nebulizer will be very beneficial to mobilize secretions, to keep the trach patent, you know, making sure it's not blocking. That is very, very important. That also leads me to inner cannula changes, our next point. Inner cannula changes, you know, many of those tracheostomies have an inner cannula, and you need to change that inner cannula. It sits in here, and it needs to be changed all the time, because if you don't change it, the tracheostomy tube can block. and that could be a major setback, right? Could be a major setback. So it's very important that you keep changing that inner cannula multiple times a day, and that you know how to prevent it from blocking to begin with, which would be with nebulizers, regular suctioning. You know, you also need to look at, you know, suctioning every few hours. Don't overdo it, because generally speaking, the more you suction, the more sputum will be produced. The goal is for your loved one to bring up the sputum themselves with coughing. You know, that's why, again, it's so important to do coughing and breathing exercises. Very, very important. You know, that these things are happening. So I hope you're following to this point. We are sort of halfway through the steps. If you have any questions in regards to today's topic, please type them into the chat pad. You know, you can also get to talk to me live on the show after I've gone through my points. But for now, just type them into the chat pad if you do have any questions to today's topic. We might have some time to answer some other questions later, depending how long we go. So here is another point that is so important and part of a proven strategies, I believe. You need an optimistic care team and an optimistic intensive care team. If you don't have that, it's going to be very difficult. You know, you need an experienced and optimistic intensive care team that they can walk you through the steps one by one, because if you don't, that's going to be a major, major challenge. So look out for your team, how optimistic and caring they are, right? If they're not, you have a big dilemma and you might need to change hospitals. But, you know, but it is important for you to make that assessment whether you have a caring and optimistic team for your loved one to be weaned off the ventilator. Now, next part of the strategy, I did briefly mention it in my overview earlier, but I think I need to mention it again. Things like natural daylight during the day, things like a good day and night rhythm are very important, right? A healthy day and night rhythm. You know, sometimes in some intensive care units, your loved one might be in a side room or in a cubicle or in a bed space that has no natural daylight, right? And that's when it gets difficult and sometimes easy to lose track of day and night, which won't help with weaning. So it's really important that your loved one gets up during the day, gets some natural daylight, even if that means they're sitting at a window. You know, ideally they can go to the courtyard, or ideally, you know, the more daylight during the day, the better. If they can get fresh air, even better. You know, but that's also why intensive care at home is so important. You know, if we can wean at home, you know, again, there is natural daylight, there is a natural day and night rhythm. It's much easier for us to get patients out to the balcony or, you know, in the courtyard or whatever the case may be. But natural day and night rhythm is absolutely critically important. Next, I did mention again as part of my overview earlier, but I do want to mention it separately again. Regular bed baths, regular showers, good mouth care, good eye care, good nose care, back washes regularly, turning your loved one from side to side, making sure they're not getting pressure sores, not getting any contractions. Really, really important. It often gets forgotten in this day and age how important good nursing care is. You know, the last thing that you want is your loved one ending up with pressure sores, ending up with infections. It would be a major, major setback. You know, and I really think I can label that as that these patients in particular need outstanding nursing care, You know, also another point that I haven't mentioned is, you know, if someone has a trach, they also need regular dressing changes, right? So that the trach stays patent, that the skin stays clean, free of infection. You know, that dressing needs to be changed twice a day at least, or if it is soiled, more frequently, right? Now, another thing that is important here to notice is that when someone is weaned off the ventilator and the trach in ICU or at home as well, that it is often 2 steps forward, 1 step back, right? So you've got to be patient. Sometimes it is 2 steps forward, 1 step back, and that is part of the process. So don't be discouraged if things are not happening as quick as you would like them to happen. It is often 1 step 2 steps forward, 1 step back. Keeping in mind your loved one is incredibly vulnerable, right? Incredibly fragile, and you have to take this into consideration when building up strength again. And lastly, I have what I think is a bonus as part of the 10 steps, and I've given more than 10 steps by now, or more than 10 proven strategies. But lastly, I have a bonus step, and the bonus step is mobilization. And I know I've mentioned it before, but it's a bit of tongue in cheek, but I do believe mobilization is so important. Successful ventilator weaning is not possible without mobilization all day, every day. Not possible, haven't seen it. You need to build up strength every day. So those were my 10 proven strategies to wean patient off the ventilator and the trach. That is for adults and for children, right? And I hope you take them to heart. I hope you keep watching what the intensive care team is doing. If you need help, you know where we are. We help with consulting and advocacy for families in intensive care, And now let's get on to some questions that have come in during the week. And if you have any questions, please type them into the chat pad, or you can join me here live on the show. If you go to the StreamYard link that I just posted in the comment section. So if you click on the link there, you can talk to me directly here. In the meantime, just type your questions into the chat pad and I will answer them. We have another about 20 minutes left or so. So feel free to ask questions now. If not, I will go to the questions that have come in during the week. Just give me 1 second. Hi, Helene. Thank you so much for attending and showing me your hands. Okay, let's look at questions that have come in during the week. One question is from Kay. Kay says, hi, Patrick. My 69-year-old mother was already a patient in the hospital, was found by a nurse unresponsive in cardiac arrest. The MRI is showing no damage, nor is the EEG. She has been having jerking movements and is on a few seizure medications as well as sedation. I would definitely like some input from you, as I feel I'm not getting the best advice from the doctors. Right. Well, she has been, number one, you unfortunately didn't share with me how many days ago your mother had the cardiac arrest, right? If EEG and MRI are showing no damage, well, that is really promising, right? If she is having jerking movements, that is certainly concerning. And it often can show towards some brain damage from my experience. But, at the moment, it's probably too early to say where this is going. If she's on anti-seizure medications as well as sedation, she might not be ready to wake up. Maybe they try to wake her up and she's simply not ready for it. You got to be patient in a situation like that, right? Also, with the cardiac arrest, what's her heart doing? Is she on inotropes, vasopressors, potentially vasodilators? Because if that is the case and she's hemodynamically unstable, she might simply need more time. Right? Has a neurologist been consulted why she's having the jerking movements? Right? But in order to really answer your questions, I would need to look at medical records or talk to them directly and ask a series of questions. Because I think, a lot of patients after critical illness are unresponsive. Doesn't matter whether they have cardiac arrest or whether they have a pneumonia. They're just coming out of an induced coma, and it might simply take time for them to wake up. That's just the bottom line. Okay, and really I would want to see what the cardiologist is saying in a situation like that. And what is the neurologist saying? Have you spoken to them? I mean, you know that MRI and EEG show no brain damage, which is really great, right? Are they potentially over-sedating her? Are they over-sedating her? Is she still on opiates, right? Can she breathe by herself, right? Those are all questions that I would be curious to find out the answer to. Okay, let's move on to the next question. And just in regards to questions that you guys are sending in, when you send them via email or when you send them on YouTube, when I read out these questions here, I'm months behind. I'm getting so many questions. So these are questions from January. So, you know, the quickest way for you to get your questions answered is either to come in live on the show here, or you go to our website, intensivecarehotline.com. You call us on one of the numbers on the top of our website, or you book a time with me. But the shortcut really is, you know, you sign up for one of my consulting and advocacy, because that is really the shortcut. That's when I can help you the most, you know. Felicia says, just want to say thank you for sharing your knowledge and skills. My partner was awakened on Tuesday. That's fantastic. Well done. That is really good news. And thank you for sharing, Felicia. Thank you. Okay, next question from Evelyn, who says, hi, Patrick. Thank you so much for your informative videos. My brother is in a similar situation. The doctor did not ask us about a DNR, but instead told us she would not resuscitate him. He has had an MRI and it was fine. I'm disgusted by the response of the doctors, saying they would not resuscitate. As you have informed me now, it is not her choice. Would you remove him from the hospital? Thank you. Saying I'm in Australia. Okay, great. Thank you so much, Evelyn, for sharing this. Would you remove him from the hospital? Well, potentially yes, but the first thing that you need to focus on is getting that DNR removed. You know, once you've done that, then you can decide whether their attitude is changing, because if their attitude is not changing and they still continue to be negative and so forth, you should potentially change hospital. It will also help if you have private health insurance. That will also help you to change hospital, because you have more choice and freedom, right? So I would definitely look at changing hospital if you think that the attitude is not the attitude that you are looking for, right? So it's really important that you as families don't put up with, you know, with any abuse or anything that you simply don't want to tolerate. It is very important that you do that. So next question from Heather. Heather writes, hi Patrick, my brother had a heart attack and is now in the ICU. He has a severe anoxic brain injury and is on life support. They are pressuring us to make some decisions, but I feel like I don't understand the implications. Yeah, sure, I get that. You know, the only decision that you probably need to make here is not to give up. You know, that's probably the most important decision that you need to make, assuming, you know, you think there's reasonable hope that your brother will improve, you know, and that he wants to live. That's probably the only decision you need to make. What are the decisions they're pressuring you to make? I know what it looks like, because, you know, I'm talking to families in intensive care every day. I do believe they're trying to pressure you to either agree to end of life care. They might pressure you to agree to a DNR. They might try and pressure you and you know, go to hospice, or might pressure you to do a tracheostomy as quickly as possible. But, you know, the reality is that before you know all the pieces of the puzzle, when you have a loved one in intensive care, which really 99.9% of families in intensive care don't understand the pieces of the puzzle, you know, you just go at your pace. You don't want to go too slow. You know, there are some time-sensitive decisions sometimes that you need to make, but don't be time-sensitive about when to do a DNR, when to put your brother to hospice, when to start end-of-life care, because, you know, that would be inappropriate. Time-sensitive decisions would be about maybe having a tracheostomy. You know, that would be a time-sensitive decision. But the first question should always be, what are they doing to keep your brother, to get your brother off the ventilator, or trying to get your brother off the ventilator and the breathing tube beyond the shadow of a doubt? That should be your most important question. Next question from James, who says, "Hi Patrick, I wish I had known about you last year. My mom's doctor forced a PEG tube on her and no one would work with her to try to get her to be able to swallow again. She got aspiration pneumonia and the hospital wouldn't even try to help her. They forced the breathing tube down her throat and just let her get worse, eventually sending her to an LTAC where she got 5 times stage 4 pressure sores and sepsis. She passed away on May the 26th of last year. I have tried filing a lawsuit against the place she passed away in, but no law firm will take the case. They say her bed sores were inevitable. I am disabled myself. I live on a fixed income and I don't think that place should just get away with the neglect they did for my mother." Wow. Wow, that's terrible to hear, James. Well, as you've heard me say before, never give consent to a PEG tube to begin with. Never give consent to a PEG tube to begin with. Okay, we've got some questions here from Pac, who says, "Hi Patrick, my mom had a cardiac arrest 1 week ago. She's 70 years of age. It took the paramedics 17 minutes to get a pulse post-arrest. She's off sedation and opens her eyes occasionally, but not with a purpose or as a response to request. The neurologist and CCU team are recommending to remove her from the ventilator because she cannot breathe on her own. I have lost hope, but this is very difficult. Is there anything I should ask that I might be missing?" Okay. How long ago did that happen? Oh, 1 week ago. Okay, so the first thing that I believe you need to know, Pac, is 1 week in ICU is not a very long time, right? I'll tell you what the question that you should be asking, which may surprise you when I say that. Don't make decisions today that you might regret in 12 months' time. Don't make decisions today that you might regret in 24 months' time. So what do I mean by that? So if you give in and you remove the ventilator today, and let's just say your mum may not make it, may pass away, or potentially that move might cause further damage, will you regret that in 12 months' time? Will you regret that in 24 months' time? Because currently you are probably in a highly emotional state, right? It might be difficult for you to see the wood for the trees, right? It might be difficult to make a rational decision in a situation like that because you are in a heightened emotional state. You haven't seen those situations before. You know, in a situation like that, it's important to stay calm and not get sidetracked by the intensive care team's agenda, which sounds to me like the agenda is to kill her, right? Well, what's the hurry in killing someone after only a week in ICU after cardiac arrest? It is not a long time. It is not a long time. Even a month in ICU after cardiac arrest may not be a long time, right? So don't lose hope after just a week in ICU, right? Also, the question that you should be asking is, have they done an MRI scan of the brain? Have they done a CT scan of the brain? Have they done an EEG? Right? So, and what does recommending to remove her from the ventilator, what does that mean? Does that mean removing her from the ventilator means to kill her. Is that what it means? Did they say that? Or did they say they can remove her from the ventilator because they think she can breathe by herself? I do believe it's the former, not the latter, but you should ask those questions. You need to be very clear in what they're telling you. But I also think what you need to be clear on here is you need a second opinion. You need someone to look at the medical records. And we can do that for you here at intensivecarehotline.com. That is what we do, right? We review medical records for our clients, and we help you to navigate this incredibly difficult territory, right? And once again, do not make a decision today that you might regret in 12 months' time, because at the moment, you're probably not in a position to make a rush decision, right? There's probably no need to make a rush decision, right? If your mom is in discomfort, in pain, okay, then maybe review your decision. But you really have to ask yourself, what is the hurry in killing someone? Why would hospitals rush into killing someone? I don't understand it. I really don't. Right? Do not lose hope under any circumstances. Right? So, next. You got to give it some time. And you really, the other thing you need to look out for, Pac, is her heart stable? Right? Is she on inotropes? Is she on vasopressors? Is she on vasodilators? Did she have an angiogram? Did they recommend cardiac surgery? Right? Next. What's the cardiologist saying? Have you spoken to them? Is this likely to happen again? What's the neurologist saying? Does she need a tracheostomy? I don't know. In order to buy her more time. Right? In order to buy her more time. Because that is what you need. You need time. Also, does she have an advanced care plan? Is there a living will where your mum documented what she wants in a situation like this? That would really help if you had that. If you don't have an advanced care plan, or if she doesn't have an advanced care plan, have you and your mum ever had the conversation around situations like this? What would she want if a situation like that comes up? That will help you in your decision making as well. But do not rush to kill your mum. That would be my recommendation. Way too early. Way too early. Don't let anyone pressure you. You have to come to terms with it, and you have to think about what is next here. Okay. Are there any other questions? Just keep in mind that I do these YouTube lives every week. Sometimes I can slot in a second one, but it's often only at last minute. I do these YouTube lives once a week. I usually do them at 10:30 a.m. Sydney, Melbourne time on a Sunday, which is currently 8:30 p.m. Eastern Standard Time in the US on a Saturday, which is 7:30 p.m. on a Saturday Central Time, 6:30 p.m. Mountain Time, and 5:30 p.m. Pacific Time on a Saturday in the US. So I do them every week around the same time. Okay. And because we are getting so many questions from families in intensive care, as you can see, I can barely read them out here. I'm months behind reading them out. That's how many questions we're getting. That's why we created a membership for families in intensive care. And you can get access to the membership for families of critically ill patients in intensive care. If you go to our website, intensivecarehotline.com, if you click on the membership link there, or you go to intensive care hotline, or you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. You also get access to 21 ebooks, 21 videos that I've personally written and recorded that help you to make informed decisions, get peace of mind, control, power, and influence, making sure your loved one gets best care and treatment. I also offer one-on-one consulting and advocacy for families in intensive care over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I talk to doctors and nurses directly, and I'll make sure the dynamics will change in your favor in no time. Because once again, I have worked in critical care for nearly 25 years in 3 different countries, where I also worked as a nurse manager for over 5 years, and where I've been consulting and advocating for families in intensive care since 2013 at intensivecarehotline.com. You can look at our testimonial sections and at our podcast section where we've done client interviews. We've saved so many lives with our consulting and advocacy. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And also, if you like my videos, I would really appreciate if you subscribe to my YouTube channel for regular updates for families in intensive care. You also get notifications when I go on YouTube Live if you are a subscriber. Click the like button, click the notification bell, make comments, make as many comments as possible. It helps us with the algorithm, and the more people we can help, the more people is when they comment, the more people we can help, because YouTube then favors our videos. You know, I think this message needs to go out to more people across the board. And yeah, share the video with your friends and families as well. So give it a like and subscribe to my YouTube channel. Also, if you are interested in intensive care at home, like I said, we are currently operating all around Australia, in all major capital cities, in regional and rural areas. We are NDIS accredited, TAC in Victoria, iCare New South Wales, NIISQ in Queensland, DVA all around the country. We have received funding through public hospitals, private health funds, departments of health, etc. We also provide level 2 and level 3 NDIS support coordination for our clients. If you are an NDIS support coordinator and you need help for your participants, you're looking for more nursing care, you're looking for NDIS nursing assessments, we can provide all of that. You know, we are the specialists in home care for ventilation, tracheostomy, BiPAP, CPAP ventilation, tracheostomy when adults and children are not ventilated, home TPN, home IV potassium infusions, home IV magnesium infusions, home IV antibiotics, port management, central line management, peak line management, as well as Hickman's line management. We also provide palliative care at home. We have also sent our critical care nurses into the home to keep patients out of ED, out of the emergency room, out of the emergency department. When we send our nurses into the home, they do an ED bypass service, also very valuable. So if you're a hospital watching this and you want an ED bypass service, you want to free up your bed blocks in ICU, we want to hear from you because we can help you. You know, if you are a critical care nurse watching this, we also have jobs currently in Sydney, Melbourne, Brisbane, in Albury, Wodonga, in Bendigo, in Warragul. We want to hear from critical care nurses with a minimum of 2 years ICU experience, ideally with a postgraduate critical care qualification. We really want to hear from you if you're interested in working with us. If you're an intensive care specialist watching this, we also want to expand our medical team, so please reach out to us as well at intensivecarehome.com. Okay, I'm going to wrap this up in a minute. I really want to thank you for joining me. I really want to thank you for your support. Thank you so much, everyone. I'll see you again during the week with some updates, and I'll see you again in the next YouTube Live. Take care for now.